Chapter 27, Precursor Lymphoid Neoplasms. When we talk about lymphoid malignancies, this includes a variety of syndromes that affect and involve the bone marrow and peripheral blood, which is classified into a leukemia, and those that present in solid tissue masses, which are classified as lymphomas, or primarily involving other kinds of lymphoid organs, such as tonsils, lymph nodes, spleen, thymus, and lymphoid tissue of the GI tract. So in this chapter, we're going to talk about all the precursor or immature lymphoid leukemias and lymphomas. Now, these classifications, although classified differently, can also occur together. They arise from a malignant change in the stem cell and the common myeloid progenitor. Similar to AML, ALLs are hematological disorders that are also classified as malignant neoplastic conditions that have a proliferation and accumulation of immature cells that also have some kind of dysfunction in the bone marrow. There can be multiple acquired mutations within the stem cell prior to differentiation or within a lymphoid precursor that gives rise to a clone of malignant lymphocyte. Now, whether the alteration be some kind of chromosome rearrangement, abnormal cytogenetic problem, or a point mutation in an oncogene, the underlying condition leads to an unregulated manner in which cells grow, as well as maturation is arrested in early stages of differentiation. They divide and synthesize DNA slowly, and they have enhanced self-renewal as well as increased resistance to cell death. Therefore, over time, this leukemic clone will expand and the neoplastic cells will accumulate. This will impair the normal process of making hemopoietic cells, and the clone expands, which is a primary cause for confirm. As for clinical findings, ALL has been diagnosed in multiple age groups. However, there are two distinct clusters that occur in age peaks. So the primary one being in the ages of 2 to 5 years old, and another after the ages of 60. The onset of the disease in children can be abrupt without any signs or symptoms. But usually the clinical picture will present with anemia, increased infections, and thrombocytopenia resulting from bone marrow failure because of the replacement of those leukemic lymphoblasts. A lot of patients will also have fatigue, shortness of breath, as well as pallor that reflect the anemia, which shows a hemoglobin of about 10 or less than. Now, fever can also result from an infection from the release of inflammatory compounds. There is petechiae due to low platelet count, and a lot of times patients experience bone pain, where in children, a lot of the times, this is overlooked due to their normal growing patterns during that age. We are going to talk mostly about B-cell and T-cell ALL, where B-cell is characterized by an inappropriate secretion of monoclonal immunoglobulins that can increase the blood viscosity and impair flow through the microcirculation. And T-cell ALL tend to be more aggressive than the B cells, and they often have extranodal and extramedullary site involvement, including an enlarged lymph nodes, as well as the liver can be present. Now, here are some initial findings for the characteristics of ALL. The white blood cell count can be increased, decreased, or within range. You can have a hyperleukocytosis of over 100, and that only occurs in about a quarter of the patients, and most commonly in patients with T-cell ALL. You will have a neutropenia. You may have lymphoblasts that are present here with an anemia in addition to low platelet count. In the bone marrow, it's going to be hypercellular with increased lymphoblasts here. Again, the WHO doesn't want to classify an ALL until it is at least 20%, and they recommend for ALLs a blast count of over 25%. You will not be able to identify a T lymphoblast from a B one. They can circulate and vary in size and have scant to moderate basophilic cytoplasm, all have a high nucleus to cytoplasm ratio with a slightly condensed chromatin, very distinct nucleoli as well. The nucleus can also be irregularly shaped, but again, we are looking for an absence of those hour rods because that's distinguishable from a myeloblast. Here is an image on the left of a peripheral smear with a couple lymphoblasts. You have a very high nucleus to cytoplasm ratio, and you can definitely see distinct nucleoli. Now here you can see that irregular shape in the nucleus with a little bit of cleavage there. Now on the image on the right is a lymphoblast from a bone marrow patient, and again, the image or morphology can mirror that seen in the peripheral blood, but again, we have a lack of hour rods and definitely more cellular within the bone marrow itself. Here's a cross-section of a bone marrow core biopsy. This specimen is really preferred for diagnosis because there's no circulating blast at diagnosis in up to 10% of all ALL patients. So the marrow cells are really good for detecting any genetic abnormalities as well. And they also reveal pockets of densely populated lymphoblasts as well as in the biopsy for the differential. So when we talk about poor prognostic indicators in all cases, these usually occur with clinical findings that are in patients that are under 1 year old or patients that are above or beyond puberty, as well as involvement within the CNS. Now, laboratory findings, you will see a very, very high white count in the presence of BCR-ABL due to the conversion of an MPN. The World Health Organization has classified the groups of leukemias and lymphomas for precursors based on B-cell neoplasms and T-cell neoplasms. We will not talk about the mature B-cell neoplasms or T-cell neoplasms this chapter. So for the precursor B-cell neoplasms, they're either characterized by a recurrent genetic abnormality and subgrouped that way, or they remain subgrouped as not otherwise specified. In addition, T-cell leukemias and lymphomas have been subgrouped by recurrent genetic abnormalities, as the pathogenesis of most T cells is not known. This morphological identification of blasts is difficult to prove peripherally or from the bone marrow. We need identification of cell lineages test either by immunologic, cytogenetic, or molecular types of studies. Immunophenotyping is really used to determine the cell's lineage as either myeloid or lymphoid and subtype them as either T cell or B cell, as well as determine the maturation stage. Now here you can see that at the early stages, the different cell cluster of differentiation cell markers that will appear in B cell versus T cell here. As for cytochemistry, TDT is very important because it's a certain intracellular enzyme helpful in identifying the cellular subtype. So most importantly, this is a DNA polymerase found in the cell's nuclei and can be present with monoclonal antibodies. It's not present in mature lymphocytes, but can be found in up to 65% of the total thymic population of lymphocytes that are positively located in the cortex, and found in very early B cells as well. Now, a cytochemical test to distinguish T cell from B cell would be the periodic acid shifts, which usually demonstrate a coarse granular positivity in especially T cells. The reactivity may also be present in AML, but we are going to distinguish the ALL from AML with MPO and SBB. In ALL, they will be negative. Let's begin with discussing B lymphoblastic leukemia or lymphoma. So here we have a neoplasm of lymphoblasts committed to the B cell lineage. This involves the bone marrow and peripheral blood, and occasionally the disease can present in the primary involvement of the lymph nodes or certain extranodal sites, in which case that would be called lymphoblastic lymphoma. The patient can have a mass lesion in 25% of lymphoblasts in the bone marrow. B cell ALL accounts for about 80 to 85% of the cases of ALL in children and about 70% of the cases in adults. Children diagnosed with this precursor ALL have a very good prognosis, and they have a long-term event-free survival of greater than 80%. In adults, the survival is a little bit lower, but depending on the disease subtype at the patient's age and diagnosis, it could be better as well. So immunophenotyping is done in addition to cytogenetics. So cytogenetic abnormalities associated with B cell include translocations, hypodiploidy, and hyperdiploidy. The most significant translocations that have distinct clinical phenotypes have been identified as T1221 translocation, T411 translocation, T922 with a BCR-ABL gene fusion, as seen with the chromosome carrying over from CML. As for immunophenotyping, the B cell lineage recommended for panels of B cell ALL to include at least one highly sensitive marker, CD19, and a specific cytoplasmic marker, CD79A. The pre-intermediate B will also express CD10, which is the common ALL antigen, or CALA. This is very important, you need to know this. The most mature precursor of the B cell differentiation stage, which can be CD10, but positive peripheral smear that has many lymphoblasts. The stain is very dark, so you will see that the nucleus to cytoplasm is also very dark, but the nucleoli are also staining in this image here. You can also see vacuoles that may be present in the cytoplasm as well, and any kind of abnormal irregularity in the nucleus can be seen. Now here is the B lymphocyte maturation pathway, and as it is coming off of the maturation phases from the lymphoid progenitor, you can see that as it is starting to mature, the cluster of differentiation or CD markers are changing as it matures. So we can catch the different changes of immature CD markers depending on how immature the cell is. So please take a look at these markers in identification for differentiating B cell from T cell ALLs. T lymphoblastic leukemia or lymphoma accounts for about 15% of all cases in childhood and about 25% of the cases in adults. They also involve lymphoblasts committed to the T cell lineage in the bone marrow and peripheral blood. If the primary site is the lymph node or any extranodal site, this is now termed a lymphoblastic lymphoma. They usually present with a really high white count and usually a mass, a mediastinal one, which is a leukemic infiltration of the thymus, that may be present as well. The lymphoblasts are similar to the ones seen in B cell ALL, but you could see more of a variation in the sizes of the blasts as well as cytoplasmic vacuoles. The cytochemistry would be similar to that in B cell ALL, but acid phosphatase would show a focal intense positivity in B cell ALL. As for immunophenotyping, the lymphoblasts in T cell ALL are usually TDT positive, CD7 and 3 positive. There has been variable expression of CD1, 2, 4, 5, 8, and 10, and can also frequently co-express CD4 and 8. About 1/3 of the T cell ALL cases have translocations involving the alpha or sigma T cell receptor loci that results in the dysregulation of the gene partner, resulting in growth enhancement. Although the acute precursor T cell leukemias was considered a high-risk disease with poor prognosis than B cell, there are current therapeutic protocols that are improving each day. T cell ALL in children increase the risk for induction failure and relapse due to therapy. In adults, the prognosis of T cell ALL may be better than that of B cell, and there may be related to a lower incidence of adverse cytogenetic mutations in T cell ALL. Here is an image of a bone marrow aspirate with a clumping of lymphoblasts, and you can see a very large nucleus to cytoplasm ratio and very large nucleoli spread out. Here are the cellular markers that are used to classify and differentiate the T cell ALLs. And you can see that there are early pro and pre-T cell markers that are differentiated, and the common B cell markers should be negative, which are 19, 20, and 22. An image of a patient with a lymph node biopsy showing the cellularity of the node being 100% cellular with very, very large nucleoli of cells as infiltrating the lymph nodes here. In addition to the cross-section of a thymus biopsy, where we can see T cell involvement and the very, very large lymphoblasts infiltrating here. Now, the WHO has classified a group of leukemias that include malignant neoplasms in which the cytochemistry, morphology, or immunophenotyping lack sufficient information to classify them into a given lineage, or in one in which the blasts have morphological or immunophenotypical characteristics of more than one lineage. They have also classified natural killer cell lymphoblastic leukemia and lymphoma. Here It's very difficult to define this because there's no specific markers for human NK cell progenitors that have been identified yet, and the NK cell progenitors can express markers that are seen in T cell ALL as well. So it's very hard to distinguish. As for therapy, there are new treatment protocols that have raised the remission rate for B-cell ALL to about 95% in children and about 60 to 85% in adults. The prognosis for T-cell is not very favorable as B-cell, and that's partly because of the high-risk clinical features. Chemotherapy is divided into several phases. First induction, then maintenance, then consolidation therapy. So induction therapy is used to reduce the disease in complete remission or eradicate any blast population. Then it's followed by a CNS phase, where most of the time CNS leukemia is the most common form of relapse in young children who have undergone some specific treatment to any kind of brain or spinal column early in the remission here. Then there is a maintenance chemotherapy kind of to ensure that remission stays and to prevent relapse.